really love mission trips. It's something that I'm very fond of, the passion of my life right now. Now that my kids are grown and gone, you have to have a new passion. So I have, first of all, want to apologize. I'm not an ophthalmic technician, so you guys already know a lot more about eyeballs than I do. But I've done the time in the OR. So 3 things that I know are true in life. I know that God is good because He's been gracious to me. And I know that family was one of God's neatest inventions, to put us in small groups of people to support each other throughout life. And the other thing that I know is true is that life is not fair. So there's a lot of suffering that goes on in this world, and the suffering is not distributed evenly. And I think we already know that, but when you get a chance to travel around the world, that really comes home to you, and you realize it doesn't matter how hard we work and think that we have earned our life here in the United States, we have not earned the peace and the opportunities and the comfort and the luxury that we enjoy. And there are people around the world working harder than us with not a whisper of a chance of ever enjoying our lifestyle. And I've thought a lot about that, and obviously sometimes we'll have those moments where we just feel guilty, and guilt is not productive. So what do we do with that sense of unfairness, and what do we do to make a difference? And I think it's better to just kind of like Helen Keller said, you know, I'm only one. I can only do a small thing, but I will do the thing that I can do. And when I look at my life and see my core values, family, God, helping people, it actually comes together perfectly. It's a perfect match for short-term mission trips, especially because my husband is an ophthalmologist. As Dr. Anderson mentioned, global blindness, the majority of it is caused by cataracts, which is reversible. The solution to global blindness is the skill of a surgeon. That's the actual solution. So since my husband has that skill, I'm very fortunate to be able to kind of push him in that direction and to support and assist, and that's the role that I find myself in and enjoy.
See, that works now. There you go. Now it works.
Thank you. Okay, here we have just some, this is the real reason that we do trips, right? These patients were in Paraguay, I believe, and we asked after surgery, we wanted to see them one day post-op to remove their patches, and we came the next morning and there they were, and there they had spent the night, and they were very excited to be able to see. As long as you allow the happiness of the people that you serve to become your happiness, then you're going to be a very happy person. So I'm going to assume, because I don't know you guys or your experience at all, if you've been on trips, if you've been in an OR, I'm going to assume that you have a minimal amount of OR experience, but that you already have some sterile technique from maybe clinic procedures or something like that in the past. I do want to mention one thing that I've seen technicians do if they come out of clinic and they go into the OR. Your sense of sterile technique might be different, because if you're assisting the doctor on moving a foreign body, for example, so you get your gloves on and you have your Mayo stand set up and you hand him his instruments, but then he says, oh, the patient needs some more Proparacaine. He's feeling that, and you're free to reach over and give him some Proparacaine, and then you pick up your forceps and pass it to him. And I know that's good and fine for clean procedures. So clean does not equal sterile. So it's really important to switch that in your brain and say, the way that we do it in a clinic setting is different than an operating room, where sterile has to be 100%. If there are some basic skills that you don't know yet, it's not a problem. Everybody's a newbie sometimes, but before you go on a mission trip, it would be very helpful if you went onto YouTube and just Googled sterile gloving or sterile technique, and there's a lot of resources available. It's interesting, when I cross-train nurses to be backup scrubs, the skill that they find the most difficult is getting their own gloves on, and it's humorous. To actually watch that. It's just so awkward, even though once you can do it, you know, it's natural and you don't even think about it. But at first, it takes a few minutes, and you really don't want to be that person in the room holding up the whole team struggling to get your gloves on. So make sure you've practiced skills like that, gloving yourself, gloving someone else, and opening sterile items carefully. So just have a little bit of that in your pocket before you go. So we're just going to go through 6 factors that You'll encounter some basic scrub tech principles, the OR environment, setting up the room, and a few pearls about supplies and instruments. I can't talk about everything, but I'm going to talk about a couple of things, as well as a review of the medications that you'll encounter on a trip, and a little bit about communication in an operating room. But all of this will be from the perspective of this is how you might see it at home, how you're comfortable and familiar with it at home, and these are the changes or challenges that you might encounter in a different setting. Okay, so today's talk is brought to you by the letter C. And why do I say that? Because a lot of characteristics that make a good scrub tech start with the letter C. You must be conscientious. This is very important. People are not going to be watching your every move, but your sterile technique matters, and it's up to you to have that integrity. Be consistent. If you are consistent with the way that you set up your back table every morning, the way that you set up your Mayo stand, the same way for every case, then you always know where your blades are, where your post-op injections are. You'll be much safer and you'll be more efficient that way. And the other way to be consistent is when you're passing instruments to the surgeon. So if you haven't scrubbed at all before, then you'll need to think about how you pass instruments, and you'll want to be really consistent because they're concentrating on surgery and their eyes are occupied with the microscope, and they really don't want to have to look up every time you're passing them something. They will tend to do that with a new scrub or someone that they're not comfortable with, but for true efficiency, obviously, you're going to want to get past that point. So when you're handing an instrument to the doctor, you are placing it in his hand, his or her hand. Sorry. My husband said, you can't just say his all the time. I tend to do that. I don't know why. His or her hand in the orientation that they will use it, so they can immediately use it. They don't want to have to be turning it upside down or changing hands or flipping it around if it's backwards. So also some good technique would be to say, open sharps. If you're passing a blade that's open, a disposable blade, you can do that, especially at first when the surgeon's not quite comfortable with passing with you yet. You can always say open sharp. And just be really consistent with the pressure that you're giving that instrument when you put it into his hand. So basically you want that grasping reflex to kick in so that it's an automatic exchange. So you put it in their hand and their hand closes around it because they feel the pressure. Okay. You want to also stay calm because sometimes things get a little crazy. Sometimes there's tension. Sometimes there's a lot of personalities that aren't calm. But your job is not to contribute to that stress. Your job is to stay calm no matter what. And don't be reactionary. So some of the things that you would naturally do, like, oh, my nose itches, I'm going to scratch, can't do that. Something's falling off the table, I'm going to grab it, don't do that. So always think before you act and keep yourself in a calm place. That's really important. Slightly compulsive, I think, is helpful. Well, I don't know how much to emphasize that because it can also be a handicap, particularly in a mission environment where there's a lot of adaptation and a certain amount of compromise that has to happen. And that's where I have struggled on trips before, but I think I'm getting there. And of course, being very careful. And the careful part is because you're dealing with sharps. You're dealing with potentially sharps that you are unfamiliar with in an environment where in certain countries, you know that there's a higher rate of HIV or Hep C. And we've had sharps exposures. There's not a good protocol in some places to get the patient tested. So then if you have an exposure and maybe it's kind of a waiting game. You have to wait till you get home to get tested, then you have to wait a few months to get the all clear, and you just don't want to go through that. So be very careful with your sharps and avoid that exposure if you can. And the other reason to be careful too is I just might mention that ophthalmic instruments are fragile and they're expensive. So let's be careful with our equipment. Make it last as long as we can. Scrub Tech's motto is full bladder, empty stomach. If you actually scrub tech at home on a regular basis, you'll totally understand that's the truth of it. And it can feel like that too on these trips. So exercise integrity, make sure that if you contaminate something that you fix it or replace it, that you're always aware of that. And do the best you can with what you have. Okay.
Next.
Yes, next. All right, so every day, start each day with a surgical scrub. And that's Laura using a scrub and betadine, making sure she's getting all the loose skin and any dirt under the fingernails. And make sure you have a really super good scrub to start the day. After that, you can use good hand hygiene in between cases with things that might be in the room if you are fortunate enough to have Avogard or all care foam. If not, you can use isopropyl alcohol works. But just make sure you do good hand hygiene between gloving. And you'll want to, next, guard your sterile field. So now at home, we protect the entire room. The whole environment is something that we care about. But that doesn't work in missions, and so we have a different mindset. And our mindset really is to just be careful of what is sterile in the room. So it's the eye, the surgical site, it's your Mayo stand, and it's the back table. Those are your sterile fields, and those are the things you're going to be concerned with. Stay alert and respond quickly. I think if you hear the surgeon clearing his throat or tapping his foot, we have one guy that does that, then you know that you need to be on your best game here. So they really don't want to be waiting for you to figure things out. So you have to stay alert. And then verifying sterility, this has to do with the instruments. The sterile field is your domain. You are the infection control preventionist. That is your role there. Making sure that nothing gets put on your sterile field by anyone or yourself that isn't sterile. So checking the disposable items, the package to make sure it has integrity before it's opened. Checking the chemical indicator in the instrument sets, making sure it was acceptable. If you don't know how to read these, make sure you'll know that before you go. Probably you already know. When white turns black, that's a good thing. Okay. Also, you want to learn your instruments as much as possible before a trip. This picture is a VOI set, I believe, and it's nicely labeled, so that would be available for anyone to learn. Learn the names of the instruments. It's going to be, put you a step ahead. If you don't, it's okay. You'll learn them that first day. But this is going to be the best way. Maybe make flashcards or just study this photo. And then once you feel like you have learned those instruments, you need to relearn. Go ahead and stay humble. Because the real name of an instrument, whatever the doctor calls it. Okay, so absolutely. And they have lots of names. So you might call it a .12 and the doctor might call it that, and you have to know that's what he calls it. And I think the blades are the thing that we've encountered the most because like the side port could be called a side port, a sharp point, a 15 degree, all kinds of names. So just really get in tune with your doctor's lingo. Okay. And then keep track of, handle all items safely. In the orientation they will be used. We did talk about that a little bit. Keeping track of your sharps is also really important. And you need to know what sharps might even possibly be on your Mayo stand because someone else might have put them there as well, and you don't want to get poked. Now sharps need to be disposed of. They need to be disposed of safely. Sometimes you might not have a sharps container, so just make one. This was one my son created for us. It worked very well. We've even used cardboard. We use whatever we can. We just make sure it's labeled. The other thing with sharps that I would mention, one trip that I was on, we went to Kenya, and we were not in a medical facility. So we actually turned a girls' dormitory room into an OR, and that had, some challenges. But the dormitory room was on a school compound. And at the end of the trip, we packed up our sharps container, which I had brought with us, and we said, okay, now what do we do with this now? Because typically there would be a service that would take care of that in a hospital. But because of the environment and because we asked and found out that all trash gets burned in the corner of the compound and where the children and the animals can access it, we realized we really had to, tape up that and bring it home with us. And thankfully, security didn't notice it when we were passing. I don't know what they would have done if they found Dirty Sharp's container, but to be responsible with that and not just leave it behind for someone else to deal with. Okay. Keep track of your meds. Anyone recognize this? This is a test. Yes. Acetone. Okay. So why is it important to keep track of your meds? They can definitely all look the same. You might have 3 TB syringes on your Mayo stand with clear fluid, and one would be your post-op injection, one might be epi if the doctor asks for that, one could be more lidocaine, so you need to know what's what. Also, we don't have labels. Labels are a luxury, so often there will not be a way of labeling things sterilely, and so again, it's a matter of being very consistent. Like personally, I always put, when I load up my Mayo stand, I always put the post-op injections farthest away from me because they're at the end of the case, and it helps me always remember what that is. I put the lidocaine closest to me. So just have your own system, whatever works for you, so that you are sure what it is. And I did want to tell you an acetone story that will help you respect the value of knowing your medications. So this was a story that I heard that came out of the DR. I don't know who was involved, and it's a good thing I don't know, but there was a doctor doing surgery, and he didn't have a scrub tech with him, but he had a doctor assisting him who was acting as his scrub. So at one point he asked for more BSS because he was hydrating the wound or something, and he was out of BSS, and there was no more on the sterile table, and so there was some open containers in the room, and so the assisting doctor went and filled up his syringe with what he thought was BSS and gave it to the surgeon. The surgeon injected it intracamerally, and immediately the cornea turned white, started to melt, and there was nothing they could do. That was acetone that had been sitting there next to the BSS, acetone for cleaning instruments, completely not labeled and not identified, obviously. And actually, I guess within a month, the eye was blind and painful, and they had to enucleate. So really worst case scenario, acetone can damage the eye. But and pray to God you never encounter any of those kinds of experiences, but it just exemplifies how important it is to know your medications, what they are, where they are, and to be giving the right things. Okay. And then number 11, principle 11, always wipe your instruments and flush your cannulated items well. Can someone tell me what that is? Hopefully you haven't seen one that bad in clinic, but you've probably seen something similar. No, it could be, but this is 1 day post-op. It's like a 3.5 plus cell, yeah, so this is TAS, toxic anterior segment syndrome. Probably you're familiar with that. You get lectured about that, I would imagine, in your roles as a tech. So now, what?
I said wait till this afternoon, you'll hear about it.
Oh, okay, so I won't belabor the point, but I will say that it is not pathogens that have caused this. It's actually non-infectious substances. And the interesting thing about TAS, it could be like detergents that were introduced into the eye on an instrument, or maybe even minerals in the water if it was not distilled water used, things like that. But most likely the culprit is viscoelastic material. And the new viscoat used on a case does not bother the eye. It's when the viscoat was stuck on an instrument and then it was baked through the sterilization process where the proteins were broken down, but then it remained on the instrument and was introduced to another patient. That is the stuff that can cause TAS. So how do we prevent that? We prevent that at home by having an incredible central processing department that does a really good job. And there's a lot more to the cleaning and sterilization than we would respect unless we've seen it ourselves. They do rinses and wipes and ultrasonic baths and more baths before they even sterilize. But in a mission setting, you are the central processing department. It's really critical that you take the few minutes at the end of a case, making sure all your instruments are wiped and you've flushed all cannulated instruments so that there's no biohazard and so that there's no viscoelastic stuck on there. It's very critical. Okay. So we can pass that. You'll hear more about TAS later, apparently. And it's a no bubble zone. This is like one of those little fine-tuning your scrub skills. So whenever you're putting a cannula or a needle on a syringe of something, always turn it upside down and flick it. Try to eject all the air. Don't have bubbles to your surgeon, because you will hear about it. The only exception to that, there are 2 times during the MSICS where they may want air. They will know when that is. They will ask you for it. So they may inject an air bubble before they use the trypan blue to stain the capsule, because it gives more space for that to happen. And they also may want air at the end of the case if they're unsure about their wound, whether it was truly sealed. Sometimes they'll leave a small air bubble in there, and that will help. So just don't give them air unless they ask for air. Okay. All right, so let's talk about safe medication handling. We did a little bit with our story there, making sure that you're wiping all rubber stoppers before entering them with a needle, that you are keeping medications consistently in places where you know what it is, that you understand that preservative-free meds are for intracameral use, and lidocaine 2%, if it's not PF, cannot be given inside the eye. And tell the surgeon what you're handing him or her. And I say especially at first, because maybe I got a little sloppy with that, but maybe you should always tell them. Maybe that's a good practice, to just always tell them what you're handing them. And then admit if you've made a mistake immediately. Like this happened to me once, I'll just admit it. It was a cornea transplant case, and I had a lot more things on the table. And I gave lidocaine 2% with preserve, when it should have been the 1% non at one point. And the surgeon started to inject it in the eye, and then I looked at my thing and I realized what I thought I'd handed him was not in that place. It was the wrong thing. So I immediately told him, oh, yeah, please give that back to me. I handed you 2%. And of course he flushed the eye a lot with BSS, and the patient was fine. But the sooner that you confess up, the easier it is to fix or undo. Yes, not a good moment. That was not a good moment. And those are moments that keep you humble. And humble is a good thing to be, okay, especially when you're a scrub tech. All right, so let's talk about the OR environment. Jim did talk about this a little bit before, but next, here is what an OR may look like at home. So this is a very beautiful space, and it has good signage and perfect lighting. It's well regulated, highly regulated, as you probably know. Did you know that you can only accumulate no more than 32 gallons of trash per 9 square feet in an OR? Did you know that masks now have to be changed for every case? This is a new one. Multi-dose vials now cannot be accessed in an OR because it's now labeled patient care area. And the relative humidity and temperature parameters, have to be monitored every day. And if you go outside of them, you must stop surgery. Instruments cannot be wet when you use them. And the dirty instruments have to be completely enclosed before being transported out of the room. Anything that's open for one patient cannot be open in the room for another, et cetera, et cetera, et cetera. So, okay, next. This is what you might find in OR in another place. And that's actually a very nice looking mission OR. I couldn't find like the real dirt floor one. But those rules that I just talked about, none of them transfer into most environments. And so what do you do with that? Do you just shrug and say, oh, well, we're not really doing American style surgery, I'm not going to worry about it? The better attitude is to say the principles behind all of those regulations is, optimal environment for prevention of infection and best case patient care, patient outcomes. And those are principles that you can take with you. You just have to adjust them to fit the space. So I have seen ORs. Can we just go back here? Yeah. On some trips where, in the Philippines, the temperature was in the 90s, and so was the humidity. In DR, we had air conditioning on this last trip, which was wonderful, but sometimes it liked to spit out water onto the patient and stuff. Yeah. In Kenya, in our girls' dormitory room, we were really thankful that there wasn't actually a door in the doorway, because we really liked the circulating air there. And in Ghana, there were glass slats in the windows and then spaces in between. And we had a few chicken feathers float in and things like that. So again, it's like you do the best with what you have, and you try to relax and not be too, anal about it. So, but we don't shrug. We say that our sterile technique is even more important in those environments because of the challenges of the environment. Why sterile technique? Next, please. To avoid endophthalmitis. So you are the infection preventionist. Nurses are trained to always think this way. A nurse in an OR is always aware of infection prevention protocol, even more so than a doctor, and that's just the truth. The surgeons are focused on surgery, as they should be, and especially in a mission environment where they're more challenged than at home and less comfortable, they are not going to be necessarily aware of all of these other things. So this is your role and your job to watch for safe techniques, safe medication administration, and sterile environment. So if, like they say at the airport, if you see something, say something. So you do sometimes have to make a call and just, I wouldn't say, hey, you touched the microscope to the doctor. You got to be careful how you say it, but you could say, doctor, would you like me to get you a new pair of gloves? And if you say that, he'll be like, oh, do I need them? Yeah, okay. So he's just not aware that he breached sterility, and that does happen, I would say, quite a lot, depending on the doctor, but it's your role to call it and to fix it. Just be nice about it. Okay, so we aim for 100%. That's what we aim for. But we realize, of course, reality is never 100%. It's more like 90 or 95. And are you going to stay up awake at night sweating about that? No, you're not. You're just going to pray. You're going to do your best. And you're going to thank God for betadine. Because betadine covers a multitude of sins. So there was a study that was published in Ophthalmology, the Blue Journal, back in the 90s, that had looked at betadine and realized it's potentially probably the most important factor of anything that we do to prevent infection. So we do betadine drops before we start surgery, and we prep the lashes and the lids with betadine swabs, and that's really important.
Betadyne's coming back around too.
Coming back around.
Even into the general surgery area.
Is that right?
Betadyne's
They're
coming
realizing the
back around.
value of it. Yeah.
But there was some flawed studies with other stuff like ChloraPrep. So, and there's been, the thing with ChloraPrep is there's a huge, it's mostly packaged with alcohol, so there's a huge fire risk.
Yeah, right, which betadine doesn't have, so that's good. Also, the patients do get antibiotics to take home and use postoperatively. Okay, so we talked about being careful and doing everything 100% right, but we do know that sometimes compromises have to be made. What are some safe compromises? On mission trips, we have multiple patients in the room. Again, just think about it like you're not controlling the environment anymore. You're just controlling your sterile fields. And that's a very different paradigm, but it's a doable paradigm. So we open a back table and we guard it. We have it open all day. We have sterile items on it all day. And this is for efficiency. This is also for good management of inventory, because you do have to share a lot. You have a limited amount of stuff that you've hauled with you. And so you split the single-use meds, you split the Trypan Blue, you split even the little packages of Wex cells. There isn't extra on a mission trip. Every piece is precious, and we use it to the fullest. And so make sure that that back table is kept sterile, keep it safe. The one thing that I've noticed that I would just like to point out with the back table use, I think in the States they say don't do that because the easiest rule is to say no, never. But the reality is that there are safe compromises, but there are unsafe practices as well. Yes?
So you're just transferring stuff to a Mayo for each individual case?
Yes.
Oh, cool.
Yes. So we open up enough for the morning. We don't want to open so much that we end up wasting it, because every item is precious. So we'll just judge for half a day, and then at lunch we can reassess. Did we really accomplish that? How many more do we think we'll have? And we try to make it so that we're using up everything by the end of the day. But it's more efficient that way, and it allows you to pull up your post-op injections all at once. So that's one of the compromises. At home it's one syringe, one needle, one use, one patient, one time, whatever they say. And if you're using it sterilely, you can use it again. So when we pull up our post-op injections on the back table, we're sterile. We're pulling them up. We pull up 6 or 8 or 10, and we use the same syringe to do that. Not a problem. Yes?
One thing I like to do when I'm doing that sort of situation is I try and cover some of the stuff on the back table with sterile towels, especially if you've opened quite a bit of stuff. Just because, I've operated where I'm next to an open window.
True.
There's
True.
all kinds of
So
things.
mention
Yeah.
the chicken feathers earlier.
Yeah, absolutely.
That's very realistic.
Yes.
Yeah.
Yeah. So yeah, whatever you can do to keep that as
Yeah.
sterile as possible is great.
Cool.
But I did want to point out, don't access the back table during a case because it's kind of a mental thing. You think that you're sterile because you have sterile gloves on and you're scrubbed into the procedure. But as soon as you've received an instrument used on a patient, you're sterile to that patient, but you're contaminated to that patient as well. So don't then think, I'm sterile, I'm going to go grab something else off the back table. That's the disadvantage of having a back table and the reason CMS says no. But if you're smarter than that and you remember not to do that, it's a perfectly safe option. So there's two things you can do. You can have the circulator put some sterile gloves on and grab it for you. You can get really good at remembering what you need before the case starts, which you will. Or you can take a sterile gauze, you know, if you pick it up carefully off the corner of the back table and then pick up the item that you need and carry it with you. There are safe ways to do it, but just be aware of that. Okay, so there's no filtered needles, and this is another one, use critical thinking skills. The point of a filtered needle is to get the glass shards out of the epi that you're drying up. If you pop your vial, the glass shards will float to the bottom. So when you're drawing up epi, just don't put your needle all the way to the bottom. Just put it halfway up and then draw up so you'll avoid the glass shards. So just be smart. Jim already talked about alternatives to sterilization. We also reuse IV tubing sometimes when we have to, and that's another compromise that we feel is safe because it's not being used to take blood away from the patient. It's being used to take BSS down to the surgical site. That's a very different flow and a different use. So we do wipe it with alcohol and reuse it if we need to. And also I don't worry about expiration dates on anything except medications. Everything now in the States has to have one by law, but it's considered sterile until the package has a breach of integrity, yeah. And also no gowns, and personally I think that there shouldn't be, if you can't use a new sterile gown for every procedure, which logistically that would be like 2 suitcases just for the gowns. So if you don't have access to sterile gowns per procedure, I think as a scrub tech it's worse to reuse a gown. And that is because mentally you see those blue arms and they're puffy and you feel like they're sterile and you're going to end up contaminating the sterile field that way. It's far better, you know, you look down and see your bare arms and that you know that's not sterile. So it helps you be more careful. So just don't use the gowns if you can avoid it. Okay.
You ever thought about using the sleeves?
Well, that would be an option.
We've had some sleeves. We've used them in the past.
Same thing.
No advantage.
No advantage. Okay.
Not really. So it's just another thing to bring.
Yeah, that's true.
Yeah.
To see them out. Yeah.
Cool.
So my facility in Washington State, I'm a manager of a small surgery center over there, and we were surveyed in October twice. So I just have a Suzy the Surveyor story. This lady that I spent 2 lovely days with was very clipboard, very attentive to detail person. And I thought she was about to drive me crazy. And by the end of the second day, we kind of had a rapport. I mean, she was a nice person. I liked her. But it turns out that she'd been a circulating nurse for 30 years. And that every single one of those years, she had gone on a mission trip to Thailand. And I said, oh, how in the world can you be the person that you are and be a person that goes and does mission trips? Because this is really, it's a difficult transition in your mind. It's hard. And she said, yes, you have to put on a different hat and think differently. She said, one trip, there was this cat that was in and out of the OR all week long, and she thought it was about to drive her nuts. And so about day 3 or 4, she finally said to hospital personnel, can you get the cat out? There shouldn't be a cat in the OR. It's just, that's too much, okay? And they said, well, we have been having a rat infestation problem, and if there was no cat, there would be rats. And she said, you know what? Now, whenever she's in an environment where she feels like this is such a compromise, she tells herself, a cat is better than a rat. Okay, and that's, yes, and I have said that to myself now, and so, a cat is better than a rat. So you do the best with what you have, okay? We can skip the next portion, which was about setting up the room, because Jim really covered that already. It's just like all the equipment that you need, and I will show you the next picture because it shows how we like to put our supplies in gallon bags up on the wall. And this is a really handy thing. 2 precautions. One is don't tape to fresh paint, is it will peel off. And you do want to be respectful of their environment. Even if it doesn't look that nice to you, to them, it's, you know, it's the best they have. But most places don't have fresh paint. So the other one is don't hang your bags directly over top of your sterile back table, because sometimes the bags fall because they're heavy, and then you would have a problem. So just put them other places around the room.
I traveled with MMI once, and they had, it was the coolest thing, it was a shoe bag. Remember those? You put them on the back of your door, and they had all those little compartments in them. Somebody unrolled one of those, and they did the same thing, and it was kind of cool, but you couldn't put a lot in them. You had to modify, but that's something to think about.
Yeah.
If I one would fit my shoes, we could put them.
So scrub tech and circulator together need to set the room up, because everyone needs to know where everything is. And that helps, especially if you're newish at what the supplies are. That will give you a good hands-on opportunity to see everything and see the name of everything. Okay, go ahead. And then the back table. Yeah. Here's just an example. We opened stuff for maybe 5 cases or 8. I don't know, but you can just see that we opened it all carefully. When you're opening sterile items, you want to make sure that you're not opening directly over the table. You're kind of flipping onto the table, and that nothing is brushing against anything. And then, of course, you're going to glove sterilely before you arrange that or split the items out into what you might need per case. And again, covering it with the sterile towels that are inside the C-packs would be an excellent idea as well. Next. Here we have, just shows the room set up a little bit more. You can see the bags on the back wall. You can see that we have made a triangle out of cardboard to go under the ophthalmic drape, so there's some air circulation for the patient. That's really key. And then she has her Mayo stand. Now this is a temporal surgeon. Some are superior surgeons. She's scrubbing on the same side as her surgeon. I always scrub opposite my temporal guys. But those kind of calls are up to you and up to the size of the room. So you have to just be really flexible. Okay, supplies and instruments. How are we doing with time? I just have no idea. I'm sorry.
We have probably 5 minutes,
Oh.
10 minutes maybe.
Okay.
I think they're going to
So,
move along too.
viscoelastics, I know. If you already know what they are, great. If you don't, there's a whole world of viscoelastics, and it's a little confusing at first because you're going to run into 5 or 6 different products potentially on a trip. And you just know that some assembly is required with some of them. So just look to see if, you know, the cap sometimes is actually the plunger, and the cannula can be separate, and just give yourself a minute to figure out how those go together. You want to hand it to the surgeon already assembled. And there's some pictures of, they might be called Helon, Viscoat, Provisc, Celluvisc, Ocuvisc, Endocoat, all kinds of names. And IOLs, this is another thing where there's a variety, and it's really good for you from a scrub tech's perspective to know a little bit about IOLs. The one piece that we use at home, typically we don't bring on mission trips because it has a thicker haptic. And so, like, this is a standard, the one on the end, the yellow one, that's a standard SN60 from Alcon. That would be something you would put in at home into the cap, into the bag, and that would be a beautiful lens. But this one over here, which is the 3-piece, it has thinner haptics. You can see that. So that's a more versatile lens. So typically that's what we would like to have on mission trips, because it can go in the bag, or if there's any kind of doubt about the integrity of the bag or the zonular support, it can also go into the sulcus, whereas the thicker haptics shouldn't go into the sulcus. And so that's a PC, which is the posterior chamber, 3-piece. And that, of course, can come from many companies, and it will come in a variety of boxes. But those will be all similar lenses in terms of what it looks like and how it, and where it goes in the eye. And then once in a while, if you have no bag support at all and you have to put in an AC lens, that would be a lens that looks more like this one, and it gets put into the anterior chamber in front of the iris and then rests in place. If there's a lens change in the middle of a procedure, then you already know something's going on. And I do have a screen about vitreous protocol that we can maybe get to if we have time. Okay. So that's my husband. His sign says, in case you can't read it, have scope will travel. And we just like to keep all of the lens containers as the week goes on to just kind of fun to see how many we've done. Next. All right, forceps. So this is only one example of the world of instruments. The reason I'm going to point this one out specifically is because this is confusing to new scrubs, because these are toothed forceps and those are untoothed, also called non-toothed. They're also called tires. And toothed forceps are generally used for anything that's going to be grabbing the tissue, and then the non-toothed for materials. So if the surgeon is taking the lens, he will want the non-toothed. If he's suturing, he'll want the non-toothed. If he's doing his peritomy or his cautery at the end of the case, he'll want the toothed. Just because one is straight and one is angled, don't let that confuse you either, because they can come either way. So that's an example of why you should be alert to the instruments and learn the actual ones that are in that instrument case, because there's a lot of differences, small differences that you don't notice at first. Okay. Every case. So there's some things you'll need with every case. Once you realize what that is, make a list if you want. Tape it up to the wall behind your back table, so when you're setting up your Mayo stand, you'll know what to pull. Next. PRN supplies. Sutures. It's really good to be familiar with the sutures you might encounter. So if they want to do a bridal suture to be able to control the eye movement, they'll use a 4/0 silk. Wound leaks will be sutured with a 10/0 nylon. And then conjunctival closure, if the cautery is not good enough to close the conj, they'll use a 7 or 8 Vicryl. And just know before you go on a trip how to load a suture. That's important. You probably all know that already, but vitreous protocol. So this is, when you hear the V word, you know that things have changed a little bit in the room, and things get kind of exciting. So some things that you'll need is if they have the handheld vitrector, that's a handy tool, and then you'll need a sterile glove to drop the head in because the head is sterile. Also, triessence and myocall. The triessence is to visualize where the vitreous strands are in the anterior chamber. The myocall will help to constrict the pupil afterwards to keep the vitreous back once it's been contained. Extra wax, possibly that anterior chamber lens we talked about, and a lot of time, so be very patient. If you ever need to call upon your calming skills as a surg tech, scrub tech, it will be when you hear the word vitreous. Okay. Medications. All right, thanks. A good rule of thumb is to always focus on the generic names. As you know from being a tech with glaucoma meds, there's like 1,000 out there, right? Depending on the company. So if you just always look for the generic names, there's less to know if you were to learn, and that's good. Dilating drops, which would be given in the block room, in the pre-op room. We like to always use a combination. So you want one from the family of sympathetic stimulators, which is your fight or flight, so like phenylephrine. And then you would want another from the parasympathetic suppressor, like a cyclopentolate. Those are pretty typical. But it's really good to know the families they're in, so that you don't want to do, everyone knows you need 2. People seem to know you need 2 types of dilating drops. Well, which 2? Well, just think about getting one from each family. Okay, and then retrobulbar blocks, usually those are 1-to-1 mixture of 2% lidocaine with Marcaine, which is a 0.75. But again, that's physician preference. Most doctors strongly don't want epi in their blocks, and some do, so just be aware of that. And then in the OR, next, we will have proparacaine or alkaine or one of those drops that we like to put in the eye, even though they've been blocked, just in case, before we do the betadine, because betadine can sting. And after the betadine ophthalmic drops, then there's the betadine swabs to finish cleaning. We also use BSS as our solution, as our water, IV fluid. And that is something that we would add a 0.5 ml of epinephrine to the 500 ml of BSS. And then your post-op injections, which would be a steroid and antibiotic, and usually dexamethasone and Ceph are good. And again, that's physician preference, so check with your doctor before you drop all of those. And then at the end of the case, when it's all over, we wipe the eye, put some ointment in it, whatever we have on hand. And then we tape it closed and put the gauze and the patches and the shield. Okay, so PRN meds would be like Trypan. Not everyone uses that on every case. They would just use it if they have a poor red reflex. It helps them to visualize the capsule better when they're making their rhexis. And then triessence, as we talked about, if there's a vitreous, maybe they want more lidocaine, maybe they'll need Myocol or Myostat. And that's about it. It's a small little world of medications. All right, the last thing I wanted to say was communication. Of course, at-home cataract patients are aware and alert, and communication at home in an OR is very controlled and minimal and coded. My husband, for example, he says, he's taught himself to say there emphatically instead of oh crap. So the patients can hear the doctor say there, and they're not alarmed by that, but the team knows what he's really thinking. So it's good to have that kind of code with communication. I know in trips sometimes you're not speaking the same language. You have more freedom to say what you want to say, but even so, be aware of your tone of voice, because that patient is fully alert and listening because they have nothing else to do. So they can hear if there's like too much nonsense going on. They can hear if there's stress or fighting or anger. They can hear if there's tension. So be careful. And don't say oops or sorry ever. Okay. Communicating with other team members, communicate as much as you need to and be clear and be persistent. So sometimes teams really gel very well, and sometimes there's some friction between team members, and I believe the friction comes from, first of all, you got to know who your team leader is, and there should just be one. And everyone else needs to really work together, understanding that the scrub tech is going to be asking people to do things for them all day long, and that's not because they're being bossy. It's because they're sterile and they can't go and get it themselves. So if you're acting as a circulator, just know that that's normal, that you need to be available and you need to be opening and handing things. And then communicating with surgeons. Surgeons are special people. They are I can say this because I'm married to one.